Okay.
Good evening, sir. My case is 75-year-old male Mr. Ambrose, residing at Alahi Bandipuram, working as a construction worker, came to the hospital with chief complaints of ulcer over the left hand for the past 1 year, sir. History of presenting illness. Patient had a history of accidental burns to the left upper limb 20 years ago and was treated at private hospital and treated with cleaning and dressing. Burns healed with ulcer. History of difficulty in using left upper limb following healing with restriction of movements at the wrist joint was present, sir. Patient sustained trauma to the dorsum of the left hand over the scar site 1 year ago and he developed an ulcer. Initially, the ulcer was about 1 cross 1 centimeter and progressed to present size of about 10 cross 8 centimeters over the dorsum of the hand. There is no history of pain over the ulcer. There is a very minimal discharge from the ulcer, no history of fever, no history of itching, no history of any other scar in the body other than the left upper limb, no history of swelling in the axilla. Past history, he is not a known case of diabetes mellitus, hypertension, bronchial asthma and tuberculosis. No history of previous surgeries, no history of drug or food allergies, sir. Personal history, he consumes alcohol about 90 ml per day for the past 40 years. Smoker for the past 40 years. 4 to 5 BDs per day, sir.
This is like a short case. Don't go very
Yes, sir.
detailed for that.
Okay, sir.
Tell the positive findings.
Sir, case summary, sir. My case summary is my case is a 75-year aged male with history of burns 20 years ago in the left upper limb, now presented with painless progressive ulcero-proliferative growth in the dorsum of the left hand for the past 1 year, sir, with no regional lymphadenopathy. No, ma'am, I could. The granulation tissue is present, ma'am, but
Okay.
below that floor I couldn't assess, ma'am, and also.
The floor is, what is the floor here?
What you see, half of the ulcer is filled with the growth. Then
Yes,
how will
ma'am.
you assess the floor? In the rest of the proximal portion, it is covered with the granulation tissue.
Granulation tissue with slough, sir.
If some
So
underlying
don't put
structures
all
are,
those things don't put. Underlying structures fixed, superficial structures fixed.
Stop then.
suppose through the ulcer, if you are able to see any tendon or even exposed bone, then you commit about the structure which is
What you are
seen.
seeing?
Yes, sir.
Other than that, fixity is not reliable in this case.
Sensory sensations were intact for him, sir. He could feel touch and temperature, sir. Vibration couldn't do, sir.
Tips also. Toe.
No, sir. Fine touch, he couldn't make it out well, sir.
Your statement says sensory sensation is normal. That means everywhere normal or what?
And, in the margins, he was not able to make it out, sir. But the fingers, he was able to make it out. It was, although it was hanging and was not functional,
You
sir.
said finger is totally edematous.
Edematous, sir.
So why there is edema?
Because of continuous hanging and due to
So
gravity.
what are the
sir.
changes will take place?
Muscle
So sensation will be normal or abnormal, increased?
has to be decreased, sir. It has to be decreased, sir. But when I asked him, he
This
told,
all problem because you are superficially committing without doing the checking. If you really look at and see the patient's sensation, then you will not make a commitment. All these statements you are making superficially, sensories, all sensory sensations normal, making it sensational.
sir, radial, ulnar and brachial pulses are felt, sir. No epitrochlear lymphadenopathy. Examination.
Why suddenly going for epitracheal lymphadenopathy?
Sir, drainage site of upper limb is through epitrochlear and then it goes to the lateral group.
This is
of
a normal
lymph nodes.
pathway.
Yes,
Epitracheal node is a normal node.
No, sir. It
In which condition you get epitracheal node?
Syphilis, sir. Syphilis will have occipital lymph nodes also, sir.
So you are
Along with
thinking in terms of syphilis here.
No, sir.
No,
Because
what made you to think suddenly epitracheal lymphadenopathy? What are the conditions you get specifically epitracheal lymphadenopathy? Huh? Hansen's very rare. You get an old epitracheal node. Non-Hodgkin's lymphomas, when you say it is non-contiguity, so you can get, but commonly a specific inflammatory reactions like infection like syphilis.
Syphilis.
So don't go and typically put as a anterior part of the hand,
Yes, sir.
dorsal part,
Yes,
where
sir.
it drains.
So it goes to the epitrochlear, goes to the lateral group of axial lymph nodes, sir.
If you go to Chennai, there is lot of pathways. You don't say that.
No, sir. It will.
Axillary, which group?
Lateral group, sir.
Lateral group.
Lateral group, sir. Go and.
Are you sure?
Yes, sir.
It's more of an anterior group. Okay, go ahead.
So other systems were normal, sir. My diagnosis for this patient, my patient is a case of Marjolin ulcer, sir. I'll grade it as clinically T4.
My God, Marjolin ulcer is a staging.
Sir, put it as squamous cell carcinoma, sir.
How do you can put it as squamous cell carcinoma? Never ever make a commitment for a Marjolin ulcer as a staging. Marjolin ulcer per se has no staging. It depends upon what kind of ulcer. Histologically, you prove it is a squamous cell carcinoma, then you grade it as a cancer for the squamous cell. If it comes as the basal cell carcinoma, you have to put it as a basal cell carcinoma. So, per se, marginal ulcer, when you are presenting, don't present with the staging. So, how do you come to in the, if it is squamous cell, it is a T4?
Sir, in squamous cell, T1 is less than 2 centimeters, sir. T2 is greater than 2 centimeters. 3, it is more than 4 centimeters or invasion into the facial bone, sir. T4 is into muscles or bones or major bones, sir. T4.
T4?
Yes, sir.
Major bone. What the major bone is infiltrated here?
I took it because like it was infiltrating into the muscles. So
infiltrated muscle is not stage T4. So that is also wrong. Staging and putting it as a marginal ulcer staging is also wrong.
also I'll change it.
What are the difference in marginal ulcer and routine squamous cell carcinomas?
Sir, for marginal ulcer there won't be lymphadenopathy, sir. But in
No lymphadenopathy.
yes, sir, because scar tissues lacks lymphatics, sir. So only when in the later stages when it infiltrates to the surrounding tissues, it will go for lymphadenopathy, sir.
So
Loco-regional.
in your case,
He didn't have anything, sir.
so is it not extended to the surrounding tissue?
Yes.
So is it an aggressive tumor or less aggressive tumor?
Aggressive tumor, sir. It is a slow growing tumor, but
Why do you say it is aggressive tumor?
latency period is very low, sir.
It is locally aggressive. Squamous cell carcinoma is locally aggressive, local regional. The distal metastasis is only 3 to 4% in a squamous cell carcinoma. You don't get it. But in a marginal ulcer, you can get up to 30 to 40% the distal secondaries can get, because it is more spreads by the bloodstream, may not be through the lymphatics. So it is highly aggressive tumor. It spreads very quickly to the distal metastasis to be there. Then tell what are the differences you will see, other differences. Any difference in the histology?
Yes, sir. This has crest form or nest-like
Is it normal for a squamous cell carcinoma?
keratin pearls will be seen, sir.
Keratin pearl will be everywhere, which will be more common in marginal ulcer or not?
So marginal ulcer, we have prickle cells also will be present, sir. And,
so it's a lot of variety changes will be there, not like a typical squamous cell carcinoma. Even sometimes keratin pearls formation will be also very less you will get. Okay. Then?
Sir, locations, basal cell mostly occurs above the line between the angle of the mouth and the tragus, sir, for basal cell carcinoma or rodent ulcers.
What is tear line?
Tear line comes in basal cell carcinoma, sir. It is tear rolling, that line only.
So what is the common site for basal cell carcinoma?
In the
Must say generalized. All sites of embryonal fusions are 4 times more common than any other site. The site, yes, the more prone for the tear shape, that region above that. But all those region is more common because it is a embryonical fusion size. When there is more embryonical fusion, you are going to get a more basal cell carcinoma. Okay, now how you are going to proceed?
Sir, for Marjolin's ulcer, most probably it will be a wide local excision, sir. But in my patient,
Wide local excision. For what? You need not confirm the diagnosis.
sir, I'll start with the general investigation, sir. So, to rule out all comorbidities, also I'll start with routine CBC, RBS, RFT,
My
and LFT,
goodness,
sir.
this is not accepted.
Sir, to confirm the diagnosis, sir.
Postgraduate coming and saying my routine TCDC, I will say.
Sir, to confirm the diagnosis, sir.
Hmm.
To confirm the diagnosis, I'll take X-ray and ma'am, confirm is edge wedge biopsy, ma'am. I'll do for edge wedge biopsy, following with
With local or without local?
without local, sir.
Why not local?
I'll have to take the multiplying cells along the margins, sir. So
No, see that will painful, no?
yes, sir.
So can you take without anesthesia?
If we want, we can do for regional anesthesia, sir, not in the local region, sir, where we are taking it.
How a patient is this patient? How will you take a biopsy? You are taken biopsy or not?
Taken, sir.
How?
Take given an axillary block and then taken, sir.
Now tell me, how will you give axillary block?
Sir, I'll have to shift, keep it for 30 to 60 degrees, and then we'll have to see for the presence of axillary artery, sir, through the then we'll have to keep 2 needles just below and one above that, and then not to injure the axillary artery.
How do you know it is inside the axillary sheath?
Sir, you can, sir,
You have put the 2 needles.
ultrasound graded you can do, sir, or if not,
You don't have an ultrasound. Hmm? How do you know you are in the axillary sheath?
You are doing blind by blind technique. Tell me 2 points to confirm it is in the axillary sheath. Once somebody is murmuring there,
pulsate.
it will
Be-
dance with pulsation.
Hmm.
Another thing, we can elicit some paresthesia in the nerve segment or also infiltrate.
Okay.
So for this,
Why not local anesthesia?
it will infiltrate the surrounding tissues and it will
Will it disturb your biopsy yield?
yes, sir.
Why?
Postgraduates, please remember the short cases are also very deciding case. It's not the long case. So ulcer, even a small dermoid cyst can be kept as a short case. And there we do not expect you to make any mistakes on the short cases because that is very commonly kept cases. Ulcer is one you are going to have commonly have. So questions on the ulcer and the swellings, lipomas or anything, need to be extremely cautious. Spend some time because most of the time we discuss only the long case and short cases will be kept unnoticed. Okay. So you must know why you should not put a local. What is the tissue plane it will create?
Usually, if you infiltrate a drug, it will take much time to absorb. So it will disrupt the epithelium and the layers of the epithelium. So that will be difficult for the pathologist to assess and give a clear report.
Then you have done a biopsy.
Then to confirm the extent of the disease, sir, I'll take a CT left
You
upper
take
limb,
CT, which is preferable in marginal cells.
sir. MRI is preferable, sir.
Why?
Soft tissue involvement can also be seen.
What soft tissue you are going to see?
Uh,
This, like what we said earlier, there is a 30 to 40% of this marginal cell has the distal spread because of the vascular involvement. So vascular involvement automatically means it's a perineural involvement. So it's more chances of perineural spread is common than routine squamous cell carcinoma, and more chances of the vascular lymphovascular involvement. So that you need to do with a MRI is the most ideal choice for doing this. Yes, nothing wrong in doing a CT, but then you must complement with the MRI.
sir.
Of the regional disease, like sir said, it involves hematogenous spread. So if you want to evaluate the distant spread, better to go for CT.
Yes, sir. Following that, I'll do for USG axilla part, sir, to see for the lymph nodes, and then I'll proceed with
Clinical stage is N0.
Win 0
Still you want to do
clinically. Yes, sir.
in a marjorie. You are suspecting marjorie.
The lymph node you want to see.
Yes, sir. In the late it can, sir.
Anything is can possible. In the
Yes, sir.
surgery and medicine, nothing you can say impossible. Even ultrasound is not right. You can do MRI, you can do a PET to see a node. Then
Then investigations for assessing the patient, sir. For that, I'll do all the routine investigations, and
please forget that we are not going to ask you the routine investigation whether we are going to do or not. Assessment, we are going to do that. That is a MD anesthesia examination. Here you are going to see that going to make the patient and fit the patient for the surgery.
I'll proceed my patient for amputation, sir. The
Straight away.
patient has a non-functioning limb with salvage procedures need not be done for this patient since it is already non-functional, sir.
Why do you say it is non-functional?
Patient can't do any movements of the wrist joint, sir.
Okay. Can we not do
It may be-
arthrodesis?
It may be due to contracture, post-burn contracture. So you need to assess that also. You think you cannot correct his deformity.
Passive movements also could not be done for him, sir.
In a contracture we cannot do anything. Only after releasing the contracture only we will be able to move the joint.
You are right. You are not seeing what you are. But
For this patient, okay.
But the approach is not like that. You are straight away going for an amputation. You should assess the things and do that. Have you looked for any other sources of this? This area is there. Your scar is there. Any other area, other squamous cell carcinomas is there?
Sir,
It has now buried down, exposed the bones, and joint is also exposed. No. Can it be a basal cell carcinoma?
could be, sir.
So what, if it is basal cell carcinoma, what do you treat? So what is the most important defects in the basal cell carcinoma? What pathway is affected?
MAP pathway.
MAP. What is the commonest cutaneous malignancy? Basal cell carcinoma. What is the commonest defect? H-dog pathway. So what is the function of basal cell? The basal cell carcinoma arises from where? What is the function of basal cell layer? What is the function of basal cell layer? Regeneration. No. What is the typical histological change when you see the basal cell carcinoma? What is the artifact you say? Retractile artifact or the basal function is secretion of mucin. It secretes mucin. It contains lot of mucin. So when you take a slide and do that, this mucin in the cells will go for dryness. So it will produce an artifact in the slides. So that H-dog pathway mainly works on that mucin synthesis. That helps in the proliferation of the cells. So what is the drug? How will you treat that drug? How will you treat what is the H-dog pathway inhibitor? Any drug? Sonidategib? So the wait and watch policy is gone. That is not what routine we are going to follow for that. So what are the sources where you get a marginal ulcer?
Sir, it can come from any chronic ulcer, sir. It can also come from osteomyelitis sinuses. Then it can come from pilonidal sinus. It can come from scarring due to flogging. It can come from gummatous scar, sir. And then it can also come from fistulas also, sir.
So suppose you have a squamous cell carcinoma and somebody who has a sarcoma at the periphery. So what is the difference in the amputations?
Sir, squamous cell carcinoma will give a 2 centimeter clearance, sir, and then we'll go for this patient 1 joint above, sir. So we'll do below elbow amputation, sir. For sir,
1 joint above.
Above, sir. Since we thought that this was
So
not
this
possible,
joint is there.
then we'll have to go for
1 joint above means
above elbow, sir.
you will need to do above elbow. Squamous cell carcinoma.
Yes, sir.
That is the difference between sarcoma and squamous cell carcinoma.
2 centimeter clearance, yes, ma'am.
That is enough. Why not radiotherapy?
Sir, it has very poor blood supply, sir. So it is, although squamous cell carcinoma is good in chemo radiation, for marginal ulcer, it is radio resistant, sir. But in case of palliation,
Who said it has a very low blood supply?
vascular insufficiency will be there, sir.
Vascular insufficiency will come. You said even the distal forearm and toes were healthy.
Yes, sir.
Then what is the insufficiency is there?
Due to excessive fibrosis, sir. Extensive fibrosis will be there, sir.
Is the site ulcer is after forming ulcer, you say typically like you're growing there. There is no deficiency of the, like just because there is a scar tissue, that doesn't mean there is no blood supply. Sufficient blood supply is there. So why in this case you will not do radiotherapy? And when you give a radiotherapy, what will happen?
So bone necrosis.
So you are going to not going to maintain the function of that. Okay.
Thank you, sir.
Thank you, sir.